Chhattisgarh Adolescent Health Academy. Warm greetings and cordial welcome to this third webinar in the series on adolescent health. So this nationwide forum discusses the key insights, informed opinions, in-depth expertise, and skilled perspectives regarding important concerns and challenges in fostering and empowering adolescent health. As we all know that adolescence is a critical juncture in life where the right support can shape a bright future. So striving for excellence, Chhattisgarh Adolescent Health Academy with its committed team has been working diligently, exerting its best efforts to provide a positive impact to enhance the adolescent health care outcomes. Now, in this series of online academic session, we have again met over here, and we cordially welcome. I guess our national IAP office bearers might not be present over here, but we do welcome them in absentia. Dr. Vasant Kalatkar sir, our honorable president, our president-elect in absentia, Dr. Neelam Mohan madam, our immediate past president in absentia, Dr. G.V. Basavaraj sir, our honorable secretary, Dr. Yogesh Parekh sir, and our honorable secretary as well, Dr. Atanu Bhadra Masar. So they all have been our guiding lights for all these academic sessions. We also welcome our National Adolescent Health Academy representative officials, our honorable chairperson, Dr. Hima Bindu madam. Madam has joined back again. Hima Bindu madam, you are here. Dr. Hima Bindu madam, you are here.
Madam will
We
be
welcome
joining
you,
in
madam.
5 minutes, madam.
Sure, sir. I guess madam has joined. Yes. We welcome madam. The chairperson-elect, Dr. Shushma Desai madam in absentia, immediate past chairperson, Dr. Geeta Patil madam in absentia, our honorable national secretary.
She is there. Geeta Patil ma'am is there.
Patil madam is here.
Great.
Yes,
We
I'm there.
welcome you, Dr. Geeta ma'am. Yes, madam. Yes. Most welcome, ma'am. And then, we have, I think Dr. P.V. Arya sir is not here. We welcome sir as well. We remember sir. Our national treasurer, Dr. Sneha Gadkar madam. Is Sneha madam present?
Oh, yeah, she is not there.
We welcome madam in absentia. So this whole national AHA team has been our inspirational figures and role models for these academic sessions. We're also pleased to welcome and we remember our President Chhattisgarh State Academy, Dr. Rakesh Padal sir, and Honorable Secretary State Academy, Dr. Nilay Mazarkar sir. We have National Executive Board member from Chhattisgarh State, Dr. K.P. Sarabai sir is present over here. Sarabai sir, welcome sir.
Good evening.
Right, sir. Good evening, sir. Then the driving forces for Adolescent Academy are stalwarts from State Chhattisgarh, Padma Shri, Dr. Pukhraj Bafna, sir. We are missing sir over here. Sir has not joined. Pukhraj, sir.
Please.
Sir, President, sir, join in between.
Good evening.
Right.
Ah.
Dr. Madhushri Deshpande, madam, is present. Dr. Madhushri Deshpande, madam. Dr. Amar Singh Thakur, sir. We welcome you all, sir. These have been beacons of motivation and catalysts for the change in Chhattisgarh. We welcome them all. We also welcome our honorable chief guest for this session, Dr. Deoras, sir. So, senior pediatrician from Bilaspur for his gracious present. And to begin with, I shall request our President, Chhattisgarh Adolescent Health Academy, Dr. Sangeeta Joshi ma'am, for her opening remarks and keynote address in her presidential address. Dr. Sangeeta madam.
Yeah. Good evening, dignitaries on and off the dais. On behalf of Chhattisgarh Adolescent Health Academy, I welcome you all in this third webinar of the series, Begin with Basics. In our last seminar, Dr. Geeta Patil ma'am had very well covered and sensitized us about anxiety and depression. And today, our stalwarts are going to take another topics regarding mental health in our adolescents. So I thank you all for joining us and making this event a great one. And now I hand over to Dr. Mala for further proceedings. Thank you.
Thank you so much, Sangeeta ma'am. Now may I please invite Honorable Chairperson, Central Adolescent Health Academy, Dr. Hima Bindu madam, for her blessings and pearls of vision. Hima Bindu madam.
Yeah, thank you, Dr. Mala. Very good evening to all the respected seniors and colleagues of RAP and Adolescent Health Academy. I'm very much fortunate that we are celebrating, all of us are celebrating the Silver Jubilee year of AHA. And thanks to all our seniors and past chairpersons who have worked so hard in the legacy. We are continuing the legacy of our past chairpersons. So this state branches, they are heart of our central AHA. And Chhattisgarh Academy of Adolescent Health Academy has always been in the forefront. We have seen how you vibrantly have conducted so many awareness programs. And today's program, especially when we see Sukanta sir doing the program, he's one of our speakers today. Then we acknowledge the presence of Dr. Piyali and Dr. Ashmi madam, Dr. Ashwini Agrawal sir, Dr. Sarabhai, Dr. Deetika, Ashok Mehta ji, Dr. Deoras sir, thank you for your, and Yogesh and many others here from Chhattisgarh. And we are looking forward for your cooperation in extending our action plans in the state branches. And we would request you to kindly be part of the cascading of our youth wellness program. So Empower Yuva is our flagship program. Very soon we'll be coming to all the state branches, and we are empowering the Yuva on youth wellness, that is the sexual wellness, the metabolic, the mental wellness, and digital wellness. So apart from this, we have this Wave 18, where we are actually stimulating our youth to take lead, and we want to listen to their voices. So this is very unique, some action plans we are doing. And again, salutations to all the leadership in the central, the Chhattisgarh AHA. And thank you for inviting me. Congratulations and all the best for today's program. Thank you.
Thank you so much, Himabindu ma'am. Thank you for all your blessings. These words of encouragement will further initiate more, will ignite like more energy for doing many things in future as well. Thank you so much, ma'am.
Good evening,
Now, may I
Pukhraj
please-
sir. Pukhraj sir has joined.
Yes. Good evening, Pukhraj sir. We welcome Padma Shri, Dr. Pukhraj Bafna sir. Sir has just joined.
Good evening. Good evening. Bafna ji, good evening.
सर नमस्कार. बापना सर नमस्कार.
Now, with
Okay,
permission
right.
from
Sir,
all
unmute
honorable
करना पड़ेगा.
dignitaries, may I please invite Honorable our past chairperson, Dr.
Good
Geeta
evening,
Patil,
sir.
madam.
Pukhraj sir, namaskar.
Pranam, Dr. Pukhraj sir.
Pranam.
Dr. Mala for giving me opportunity. I'm not repeating all the names, but I know that Chhattisgarh IAP and AHA are doing a great job. And every time there is a mind-blowing and there are a lot of insights into different type of issues which we deal in day-to-day practice. Now, today's is Externalizing Disorders by Dr. Sukanta sir and Eating Disorder by Piyali madam. Definitely it is going to benefit us. I'm seeing many stalwarts from Chhattisgarh AHA and IAP, and I'm very sure this program will be beneficial to everyone. And I wish all the best for a happy learning. And without wasting much time, I'm handing over back to Dr. Mala. Thank you very much. Good evening, Dr. Himabindu madam, and all Sukanta sir, Rashmi Dwivedi madam. I think our very important person, Sangeeta Joshi madam, is so active and she makes everyone to be present so that the program becomes very successful. Thank you very much.
Ma'am. Thank you, ma'am. Thank you.
Thank you so much, Geeta ma'am, for your words of encouragement. Thank you so much, ma'am. Now, may I very humbly request Honorable President Chhattisgarh, Dr. Rakesh Pardal sir is present over here. Rakesh sir, possibly.
He is there.
Sir has.
He is there.
Yeah.
Yeah,
Dr.
good
Rakesh
evening,
sir.
everyone. Yeah, I am here.
Sir, your
Am I
blessings,
audible?
please. Yes,
Am
sir.
I audible?
Yes, sir. You are
Yes, sir.
audible.
Yeah. Good evening to everyone. Himabindu madam, Geeta Patil madam, Sukanta sir, Sangeeta Kiran, Padma Shri Pukhraj Bafna sir, my mentor, Dr. Rashmi Dwivedi Madam, good evening. And Sangeeta, today's webinar is very well this thing organized by help of Sangeeta Joshi and Sukanta Chatterjee and Piyali Madam. I hope that we all will be benefited by the topics they have chosen for today's evening session. The Sukanta sir is very well known, and I hope that he will guide us about the adolescents with the externalizing the disorders like aggression and impulsivity and the rule breaking, this thing, and negative outcome of this leading to the delinquency and all. And Piyali Madam will take the topic of eating disorders in adolescents. So I hope that IAP Chhattisgarh and CGAHA will be benefited by their deliberations. I welcome all the delegates and the honored speakers for this session. So please continue.
Thank you so much, Rakesh sir. Thank you so much for your words of wisdom. Thank you so much, sir. Sir, may I now please request our National Executive Board member, Honorable Dr. K.P. Sarabhai sir, for his opening remarks. Sarabhai sir.
Thank you. Thank you. Thank you, everyone. Thank you, Mala. I will just say that we welcome everyone in this prestigious program. Chhattisgarh IAP, as a matter of fact, with the blessings of Dr. Pukraj Babna sir, Madhushri Deshpande madam, Dr. Deoras, and all seniors, we are going ahead in a big way, particularly in this chapter of Chhattisgarh. And I remember Dr. Sukanto has told me on phone a couple of days back that he has already visited Chhattisgarh a couple of times and is very much interested in visiting it here again. So we cannot invite him right now.
Noted.
Definitely. But definitely, let us hear the words of wisdom from him tonight. Thank you, sir. Thank you, everyone.
Sure, sir. Thank you so much, Sarabhai sir. Before we start the scientific session, now may I please invite our chief guest for this academic session, Dr. Deoras sir, for his insightful words. Dr. Deoras sir.
Yes, I'm here. Good evening to everybody. I sincerely thank the organizers for giving this opportunity to chair, to be a chief guest of this function. I was originally a member of Adolescent chapter right since Dr. C.P. Bansal's and M.K.C. Nair's sir's time, and then I left this place. But again, I am happy to note that since last year, we are having so many adolescent chapter meetings in WhatsApp and group meeting, that again we are sensitizing our adolescent knowledge. And I sincerely thank Pukhraj Bafna sir, who has and Dr. Madhushri Deshpande madam, who have given a good memento to this this adolescent chapter of ours of Bilaspur. Dr. Sukanta sir was with me when I was CIP member in 2006, and I welcome him and I will hear his wisdom. I sincerely thank everybody, and without wasting much of your time, we want to listen you. Dr. Sukanta sir, please do start.
Yes.
Right. Before sir starts, may I please invite to chair the session our eminent figure, like esteemed member from state of Chhattisgarh, Dr. Ashwini Agrawal sir. Sir has been in various capacities, in many positions, has been in the state academy, actively involved with the academics, and sir has also received fellowship Indian Academy of Pediatrics in 2023. May I please invite respected Ashwini Agrawal sir to introduce our honorable speaker. Ashwini sir.
Thank you, Mala Madam. And I am firstly thankful to CGAHA Group as well as Central AHA for inviting me as a chairperson of the session. I welcome Dr. Sukanta Chatterjee sir for his deliberation. To introduce him, अब सूरज को आईना दिखाने वाली बात है. He is a former professor and HOD of pediatric department of Calcutta Medical College. He is presently a EB member of Central IAP as well as he was also in 2024. He is a coordinator of joint professional group of AHA, IAP, FOXY, IPH on adolescent sexual and reproductive health. He was the organizing chairperson of Adolocon 2022, and he was also a president of IAP West Bengal during 2008. On his credit, he has many public PubMed publication about 30 index publication in PubMed as well as many journal review. He is the right person to address the subject as he is running a adolescent clinic in last 14 years. And today's topic is to approach to an adolescent externalizing disorder. It is the spectrum of disease which from ADHD to OD and CD. And when we will not properly manage it, it may create a havoc to the society in the future. So it is the right person to address the problem of adolescent in right time, and then he will guide us to how to approach these cases. Now over to Sukanta sir for his deliberation.
Good evening and pranam to all my seniors. Particularly, I should start with Bhattacharya and then the Chhattisgarh Academy of Pediatrics. But before that, I must recognize and welcome the presence of Himabindu Madam, the chairperson of the Adolescent chapter, and then Geeta Patil Madam, and then the Chhattisgarh IAP, this president and secretary, and the Kiran Shankar Deoras, the Rakesh Pardal, we are talking very frequently, and the Sharabhai will be meeting again in the next EB meeting, and many other members, and the Chhattisgarh AHA particularly, who is communicating with me repeatedly. Today also, I called twice the chairperson. So I'm very happy Sangeeta Madam immediately responded. And all the members and my co-speaker, Piyali Madam, and also my chairperson who has already introduced me, and all the members who are present here. Today the topic, let me share the slide first. Now, my topic is approach to externalizing disorders in adolescents. Well, if we want to define it, then it's a mental health disorder characterized by behaviors directed outwards or towards the external environment, such as aggression, impulsivity, rule breaking, which disrupts the individual's life and the relationships with the immediate social contacts, like say families, friends, and others, causing problem in performance of the individual, like in social interactions, relationship, and daily functioning. So this is a mental health disorder. The common examples are the conduct disorders, oppositional defiance disorder, ADHD, and even substance use disorders, and many others. Now, when we talk about mental health disorder, most of the pediatricians like me think that, well, this is not my cup of tea. I'll not be able to do justice to it. So, particularly for adolescents, for their behaviors, we always say adolescents do behave like this. It will pass off. Please wait. So that really brings in the possibility of the delayed diagnosis and delayed management. On the other hand, if we are more sensitive, then most of the cases, any behavior deviations or issues that we might refer to psychiatrists. Most of them, the referrals are not honored. And again, there is a possibility of delayed or unnecessary referral. So what to do? For that, we need to know a basics of psychiatry. I'll just take 3 slides on this, the basics of psychiatry, because the way I understand psychiatry, it's just like mathematics. And rather, it is more simple than the physical health disorders clinical medicine. And in that way, I'll explain you in next 20-25 minutes how we can make a diagnosis. Now, psychiatric disorders are basically a branch of medicine that deals with thoughts, our feelings or emotion, and behavior. Now, thought or the reading of the mind is most difficult part. I think most of us are not able to do that. Those who are successful in doing or developing romantic relations in their college life, they could have read the mind of the partners. So that is the most difficult part. It's not like palpating a liver or spleen or making a diagnosis of malaria or cholera. Similarly, emotions are also difficult to read. Behaviors we can see, of course, but whether that behavior is normal or abnormal, that needs to be clearly defined. For that clear definition, let me take an example that all our behaviors are coming in response to the situation we are exposed. Suppose we see a dog sitting on the footpath through which I want to go to reach my destination. The thought that comes in my mind, that dog will bite me, that thought will immediately develop a feeling that I'll be afraid that dog will bite me. And then I'll not proceed further. I'll run away from the destination and take a different path to reach the destination. But if I change the thought, well, others are passing by the side of the dog, nothing is happening, and dog doesn't bite without provocation, then I'll not feel afraid. And then I'll travel along the footpath by the side of the dog and reach my destination. So it's the thought that influences feeling and our behavior. In that way, we should always consider while diagnosing a mental health problems or issues. And psychiatric illnesses are deviations of either thought or feelings or behavior or a combination. That's how simple way we can explain it. Now, next thing is how we diagnose it or how we get informations from our patients. The patient or adolescent himself may say, I am frightened, sad, or worried, means he's talking about his feelings. Or he may say, I am thinking strange thoughts, having trouble concentrating, or want to die, means he's talking about his thoughts. The parents might also describe, but we, the clinicians, first of all, ask the adolescent what is his or her thoughts or feelings. He might describe it, may not, of course. the adolescent says he or she does this or that. That means the reported behavior. We can observe the adolescent. That means we look at the adolescent, the personal care. Say suppose the combing of hairs, the facial care, then the dress, the sounds, how he talks. All these might give us clue about the adolescent thought, feelings, and behaviors. And then what others like parents, teachers, the friends, siblings tell about the adolescent, what they does means the behavior, or what adolescent says means our thoughts and feelings. We can also observe the adolescents during interaction with other people. If nothing or something is observed or detected in that, then we can also do a complete psychosocial history assessment by heads assessment. And finally, we can do general examination to exclude the physical examination and also take help of medical records. That's how we proceed. Now, the next basic thing that I want to mention is that the mental well-being is at one extreme, the other extreme is the pure psychiatric disease or disorder. So mental well-being, we all know a state of well-being where one can realize his or her abilities, cope with the stresses of life, work productively, and contribute to their society. So that is well-being. Now, when this well-being is disturbed, the person will be in stress or feel distressed, and that will come either in thinking or feeling or behavior or in combination. But that will not affect the performance of the adolescent either in academics or in social communication. It will not also interfere the or make the other persons near social contacts in stress, means the family members or friends and others. So that is the adolescent themselves will be in stress or feeling stress. The next stage, when it proceeds further, it is the mental health problems. There the distress is also passed on to the neighbors or the immediate contacts, and also it affects the performance of the adolescents. But it's not satisfying the DSM criteria to call it a pure psychiatric disease. So that is the process of the mental health difficulties or problems. And then finally, the DSM satisfied mental health diseases. But remember that a person who is mentally unwell today will become mentally well tomorrow if it is managed properly, and they are interchangeable. And earlier we detect and address, better is the outcome. Now, having said that, we are coming on to the today's subject. Externalizing disorders are mostly fall in disruptive, impulse control, and conduct disorders that includes conditions involving problems in self-control of emotion and behaviors. While other disorders in DSM-5 parameters may also involve problems in emotions and behavior regulation also, but we'll be able to diagnose them if we follow the exact criteria of DSM. In means psychiatry, the DSM is like that combination of syndromes as we go in cases of, say, rheumatic fever, Jones criteria, or say Kawasaki disease, the clinical criteria. So these are psychiatries like that. We go by combination of signs and symptoms, and that makes the diagnosis. But externalizing disorders is characterized uniquely in that these problems manifest in behaviors that violates the right of others. So that is aggression or destruction of properties, and or that brings the significant conflict with the societal norms or authority figures. Now, the first clinical question that we should decide, is this behavior normal, particularly in an adolescent? Whatever behavior we get, we might think of that, well, this is a adolescent-like behavior, and that will pass away. That I have already told you. But unless we know the clear-cut boundaries, when the normal boundary ends and the abnormal boundary starts, we might be landing with delayed diagnosis or, say, inappropriate diagnosis. And naturally, the intervention and treatment will be delayed. So the disturbances in behavior that is associated with distress in the individual or others in his or her immediate social contacts like family, peer group, school, work colleagues, or it impacts negatively in his performance like social performance, educational, occupational, or other important areas of functioning or performance. That is what is slated in DSM-5 latest scale. Now, internalizing versus externalizing disorders. Externalizing disorders involve outward directed behaviors like aggression, rule breaking. Internalizing disorders involve inwardly directed or withdrawn type of behaviors like depression, anxiety, and social withdrawal. Now, examples of externalizing manifestations of internalizing disorders. That means it's a case of anxiety or depression, but sometimes they might present with some behavior problems. Say, for example, the anxiety might exhibit temper tantrum, difficulty in transition, or some flimsy behaviors as a way to cope with their anxiety. Similarly, a depression might become withdrawn, irritable, engage in risky behaviors as a way to numb their feelings. Social withdrawal, similarly, might affect peer relations and potentially engaging in disruptive behavior to gain attention. How to differentiate then primary externalizing disorders from internalizing disorders subsequently coming or presenting with externalizing disorders? We first of all consider which symptom came first. If it is internalizing disorders, then the depression features, then anxiety features will come first. Subsequently, the features of the abnormal behavior came. That is one. Secondly, we should always strictly try to match the DSM scale. If the DSM scale match with externalizing disorders, then it is externalizing disorders. If the DSM scale match with internalizing disorders, depression or anxiety, then that is depression or anxiety disorders with some other manifestations or comorbidity as externalizing disorders. In that way, we decide. Now, brain chemistry. Well, it is said that there is altered prefrontal cortex brain morphology in adolescents and children or individuals who had this externalizing disorders. But its degree of the damage or the change and the type of the clinical manifestations are not correlated. The characters of externalizing disorders may be aggression, impulsivity, hyperactivity, rule breaking, disruptive behaviors, inattention, and others. Now, let us take just examples. Aggression may be verbal aggression or physical aggression. And physical aggression may be again a fist or fight, or it might be with the weapons. So that will ultimately decide whether the condition is severe enough or categorized as severe, moderate, or mild, something like that. So that will come, I'll talk later. Then rule breaking is also important. Disobeying rules, cheating, stealing, destruction of properties, impulsivity, acting without considering the consequences, hyperactivity, difficult to stay focused or still, inattention, not able to follow instructions. So what is the outcome of all these? Academic problems, difficulty in school due to inattention, impulsivity, disruptive behavior, peer relations problems because of developing a relation and maintaining. Mental health issues, particularly they might develop subsequently anxiety or depression because the adolescent might see that I am doing this type of behavior which I am not able to control, and that leads to anxiety or depression. So they are more prone to develop this sort of mental health issues subsequently. Substance use disorder are more likely in children who had or adolescents who had this type of externalizing disorders. They often come in confrontation with the legal frameworks. So early intervention is important. For that, early identification is important. Family involvement, particularly family dynamics, is known to be the causative factor and also curative factor for this externalizing disorders. We have to consider the comorbidity presence like anxiety, depression, that also needs additional attention. Then long-term consequences like additional mental problems, substance abuse, then criminal behaviors and others we have to consider. So common disorders are oppositional defiance disorders, conduct disorders, attention deficit hyperactive disorder, most of us are very familiar to it, substance use disorder, when the abnormal behavior is not seen, or rather seen beyond the period of say normal substance induced period. Suppose in alcohol, we see say 3 hours or 4 hours of say abnormal behavior, that is alcohol induced behavior. But beyond that, when the alcohol level is normal or gone down, still the abnormal behavior continues, then they are really substance use disorders. So then there could be personality disorders or antisocial personality disorders, pyromania, that is immense desire to set fire without any monetary gain or primary gain of the individual. Similarly, kleptomania is also an intense desire to steal without any monetary or personal gain. So intermittent explosive disorders of say accumulation of tremendous anxiety, and finally they explode in abnormal behaviors, and that lasts for usually half an hour and then it passes away. But remember, in all these disorders, the DSM has set up say criteria 1, 2, 3, 4, and this, that, and if we are able to match, then only we can diagnose this disorder. Otherwise, what I'm saying is only an outline. Now let us take a case scenario. So Rohan, 15 years old, a student of local high school at Bidhannagar, Kolkata. He frequently argues with his parents about daily chores and the inhibitions and the school assignments, often refusing to comply with their request. Is it normal or abnormal behavior of the adolescent? 15-year-old. Well, I told you that we need sharp demarcation criteria to decide whether normal or abnormal. For that, we need further information. Let's proceed. Rohan consistently displays a pattern of defiance and argumentative behavior, particularly towards authority figures like his parents and teachers. So this is something which is not simply the art of knowing something, or there he's not questioning, he's arguing and also challenging the authority. At school, he is known to be being disruptive, challenging teachers' authority, and deliberately annoying his classmates. Means multiple persons he is disturbed. Now, he blames others for his mistakes, struggles to accept the responsibility for his action. Rohan also exhibits a tendency to lose temper easily and become irritable when things don't go his way. He often engages in spiteful or vindictive behaviors when he feels something is wrong on him. Rohan's academic declines. He has difficulty maintaining friendship due to his argumentative and hostile behavior. So Rohan has got problems of say, feelings, problems of behavior, and it is not only affecting him, but also affecting the multiple persons in his near social contacts, and it's also affecting his performance, both socially and also in academics, not able to develop relations or sustain relations with the friends. So this is a clear case of abnormality. Now, what abnormality? That let us now proceed. So what is the diagnosis? If we now take up the Gita of mental health, the DSM criteria. This is a picture from the DSM-5. Let us scale. Opposition defined disorder. It's a pattern of angry, irritable mood, which Rohan has, argumentative defined behaviors, and vindictiveness. But it must be lasting at least 6 months, as evidenced by at least 4 of the symptoms that is slated below. So, often lose temper, often touchy and easily annoyed, often angry and resentful, often argues with authority figures, often actively defies or refuses to comply with requests, often deliberately annoys others, often blames others or his for his mistake and behavior. So all these criteria are fitting with Rohan, and also he is vindictive. But the point that is missing, how long it was present, that is not mentioned. It must be present for 6 months. And then above 5 years, the behavior should be at least once per week last 6 months. So this is, say, once in a week for last 6 months. If it is present, then only we can call this as oppositional defiance disorder. But in addition, the Rohan has to fulfill the criteria B also. The disturbance in behavior is associated distress in the individual and his or her immediate social contacts that I have already mentioned, and also negatively impacting the social, educational, or other areas of performance. So Rohan is having that. And the behavior do not occur exclusively during the course of, say, psychotic conditions or substance use or depressive disorders or other things. So this is to exclude that it is not under the influence of other disease. And then since it is occurring in 3 or more settings, so it's a severe condition. So that is how we classify it. So key behavior indicating ODD in Rohan: defiance and argumentativeness, disruptive behavior, blaming others, difficulty with compliance, irritability and anger, and vindictive attitude, and poor performance. So additional information that we need, how long these symptoms are present. We took this history, it was more than 6 months. How frequently? It is occurring once or more in a week for last 6 months. So it's an oppositional defiance disorder of severe right. So this is just like mathematics. As I told you that if you go by the strict criteria of DSM, and if it matches exactly, then that is that disease and that severity. It's so simple. Now, that disorder is also like that. It is essentially a feature of conduct disorder. It is a repetitive pattern of behavior in basic rights of others are violated. And there are 4 areas: aggressiveness, non-aggressive conducts, then deceitfulness or theft, and serious violation of rules. 3 or more characteristic behavior must have been present for the last 12 months, with at least one behavior present in the 6 months. So these all are components of DSM criteria. If that fulfill, then we'll call it a conduct disorder. Similarly, it should negatively impact the function, and it should have in multiple settings also. Now a case scenario: Nikhil, 16-year-old boy who exhibits a pattern of aggressive behavior, including frequent fights, bullying, and property destruction. He also known for lying and absenteeism and demonstrating a defiance for rules and rights of others. Nikhil shows little remorse or concern for the harm his action has caused to others, often dismissing their feelings and blames them for their behavior. So Nikhil's behavior patterns, aggression is there. He has often using weapons like a bat and others, or broken bottles. So this is again a serious form. If he uses a fist, then that is moderate, and if he uses some weapon which can lead to grievous hurt, then it is severe form of, say, conduct disorder. Then bullying, property destruction, then deceit or rule violation, lack of empathy, doesn't care. There is no remorse or concern what he has done, what harm he has done to others. So impact, Rohan, is disruptive behavior has led to suspension in the school and academic struggles, impacting his ability to learn and maintain positive relation with the teachers and peers. Family is struggling also to control his behavior, and community is afraid of him and wanting some action against him. At that stage, they came for intervention. So diagnosis, it is additional information that is required. At least 3 of the symptoms as per DSM 5 criteria must be present for last 6 months. At least one of them is present in last 6 months. Age of onset, if it is before 12 years, then we call it, say, adolescent subtype. Otherwise, it is post-adolescent. So it's a conduct disorder of severe variety. That's how we go. It's as I told you, it's like simple mathematics, but you have to exactly match like Jones criteria, or say, what do you call Kawasaki disease. If it doesn't match exactly, the case should be under observation or follow-up, and like we call it atypical Kawasaki. Now, lastly, for management, I must say that there are three types of management to start with: either pharmacotherapy, or cognitive behavior therapy, or counseling. When the thought process is abnormal and the adolescent or the patient cannot be convinced to alter the thought or challenge the thought, in that case, the cognitive behavior therapy is not possible, because in cognitive behavior therapy, the patient has to take the challenge the thought and take the what you call uh, the fear or other anxiety that he is facing, face that fear or anxiety. So he will not go towards the dog, or even try to go from the other footpath, keeping a distance also, because he is convinced that dog will bite. So in that case, from the very beginning, we need pharmacotherapy. That's very important to understand for us as pediatrician, and psychiatrists can treat, or even we can treat, but it is the pharmacotherapy from the beginning. Subsequently, when he is able to understand the reasoning and all that, then we might add the cognitive behavior therapy also. And those who are having mostly neutral thoughts, but doing negative behaviors, they could be convinced about their negative behaviors, and they could be treated with counseling. That's how we go, the basic principles. I'm not discussing the details of the drug treatment and other things. That is a long course. And neither we are discussing all the externalizing disorders that I have. Just I have taken two examples because I have already taken a lot of time. So I'm stopping here. And if there is any issue, feedback, you can send me an email or to my contact numbers. But I'll invite all of you to come to Kolkata Pedigon, which is the national scientific event we do annually from Indian Academy of Pediatrics. This time we are hosting it. And I personally invite all of you to come to Kolkata Pedigon and enjoy the scientific feast. Thank you.
Thank you, Sukanta sir, for your excellent deliberation. It is a very vast topic and it cannot be covered in half an hour time. And there is a lot of queries arises in these cases also. And some of the few queries which I got in my mind and also in some of the listener, there is some relation with the genetic is also associated with more chances of having a this type of conductive.
Hello.
Can you throw some light on that, sir?
Okay.
Hello.
ओके खाना वाना हो गया ठीक है ठीक ठीक ओके ओके ऑल द बेस्ट
One of the questions from Dr. Madhusri madam is what is the time duration for
Sir
to diagnose the
has
conductive
already
disorder?
answered in his slides, sir.
Yeah.
Thank you.
Any genetic linkage of this disorder with the other in the family?
Yes, sir. Yes, sir. If there is a family history of conduct disorder, then that is more likely in favor. But these things are not exactly correlated that the genetic is the family history or say genetic predisposition means it will be there. We will always go by the DSM criteria to make a diagnosis, and we will always go by the principle of treatment, pharmacotherapy or CBT or counseling, by the principle that whether the thought could be challenged by the individual and he could be convinced to take the CBT, or we need to start pharmacotherapy, and then once the thought could be controlled or challenged by the individual, then we can add CBT to it. So this is how the principle we go.
Okay, sir. And further query will be dealt after the second lecture. If you
Yes,
are,
please.
yes,
Yes.
you
Ashwini
permit.
sir, if that is a query and sir permits, can I add
Yeah,
on to what sir has said?
Yes,
yeah,
please,
yeah,
please,
yeah, yeah.
please.
Go ahead,
Yes.
madam.
So when you say genes, yes, there are genes implicated in it, but no single gene is responsible, but multiple genes are involved in this. So the genes which are responsible for dopamine regulation, it's called DRD4 and DAT1. Then genes which are responsible for monoamine oxidase A, which regulates aggression. Then SERT, serotonin transporter genes. These are a few genes which we can name that they are actually involved genetically. And for ADHD, there's a huge amount of high estimate of externalizing heritable disorders. For conduct disorders and for ODD, almost 40 to 50% heritability. So whoever asked the question, it's a wonderful question, and it's a wonderful to know that yes, the heritable factors are really, really there. But then it is not only the heritable factors, they are combined with the environmental factors. As sir was saying, they must fit the criterion of DSM. So the parenting style, the abuse or the neglect, and what is the peer influences, all of them will go together with the genetics, and then the final expression will come.
Right. So that is true. And for a clinician, our aim is to make a diagnosis and what are the factors that could influence now my patient. So say family dynamics and others that will influence the outcome of my patient. So those are important. But genes which are there, whether it is XYZ or there is 3 or 5, that doesn't matter to me when I treat a patient. That's the important. So these are all important, I should say, knowledge part. But while treating patients as a clinician, they are less useful than the point of making a diagnosis. That is very important. That is very important.
Sir, I just wanted
Thank
to
you,
ask one
Sukanta sir.
thing.
And now I hand over mic to
Ashwini sir, can
Mala
I come
to
in
for
for a
further
minute?
proceeding.
Yes, please,
Sure,
please.
sir.
Ashok.
Yes,
Sukanta sir,
Ashok, sir.
suppose there is a history of conversion. The father is a hooligan, conduct disorder or like that, and the child is growing. Is there something where by which we can predict the future outcome in a child of such a person? There are
Well,
some sociopaths, they've got children. So do we have
there are many
anything
movies
predictive?
like on this type of fictions that father is vegan, and then what will be what the son ultimately came to be. Yes, there are genetic predisposition, but the environment, family dynamics, they all help. And the as we say for mental health, the most important is family dynamics and the one-to-one relation with the mother and the father. Fortunately, in Indian context, father is in less contact with the children because he remains mostly outside. So it's the mother who is rightly called the pivot of the family. And if the mother's contact is say positive, then the child might grow out of the family environment, but definitely that will influence.
Okay.
Thank you, sir.
Thank you, sir. Now I hand over mic to Mala madam for further proceeding.
Thank you so much, Ashwini sir. Thank you for chairing the session, Ashwini sir. And thank you again, Sukanta sir, for such a wonderful talk. Thank you so much, sir. So we have a second scientific session, and our honorable speaker for the session is distinctly recognized, very well known, Dr. Piyali Bhattacharya, madam herself. Madam shall take the topic approach to adolescent with eating disorders, and to chair this session, we have our consultant pediatrics and director of Star Children Hospital, Bilaspur. And currently, sir is also the president, Bilaspur Academy of Pediatrics. Sir is MD with a fellowship in neonatal point of care ultrasonography as well. May I please invite Dr. Pritish sir to to introduce Madam.
Thank you, Mala.
Pritish sir. Yes.
Thank you, Mala Chaudhary. I am thankful to CGAHA for choosing me to chair the session. Dr. Piyali Bhattacharya, she is a professor in SGPGI Lucknow, Vice President, CIP Central Zone, UP Adolescent Health Academy, and other various IIP posts, and awarded fellowship from the Royal College London and from the IIP. Won various oration awards, various publication in textbooks and journals. As she needs no introduction, she is the right person for this topic of adolescent approach to adolescent with eating disorder. As this in day to day, it's OPD, we face these type of problems. So it's very essential for us to know. So thank you. I request Dr. Piyali Bhattacharya for this session.
Thank you, Pritish. Thank you so much. So I'll just start my session. Can you see my slides?
Yes.
Yes,
Yes.
ma'am.
Yes, ma'am. It's visible,
So
ma'am.
we need to understand how we eat. So when I say how we eat, there are 4 types of eating. So one is fuel eating. So you're eating food that supports your body and its needs. Mane scooter mein petrol dal rahe, acha wala petrol dal rahe. Then you have fun eating. That is food which you love to eat, may not give you back much nutrition or anything at all. Then there is fog eating. You are watching the television and just eating anything. And then there is storm eating. There is binges. You are eating and eating is out of control. अब सारे लोग ये सोचिए इनमें से आप कौन सा वाला करते हो? Out of this fuel eating, fun eating, fog eating या storm eating या a mixture of all of them. So when we are defining eating disorders as per the DSM criteria, remember that there are salient things that must be noted. That there is a disruption in eating behavior. It is not a normal eating behavior, but there is a disruption. Next, there is excessive concern. हम सब लोग सोचते हैं हम सुंदर हो जाएं, but excessive concern is the thing that is here in eating disorders about body weight. And all these things must impair the physical health or the psychosocial functioning. माने उसके daily routine में वो ठीक से काम नहीं कर पाएगा because of disrupting in the eating behavior and with the excessive concern about body weight. Only then we say it is a disorder. तो जब हम देखते हैं कि what is the data which is available in Indian research, we see that in India, very few researches or original articles have come out which define severe eating disorders. And one of these studies in adolescents aged 13 to 17 years have found that it is disturbed eating is there in about 26.67%. But the risk of having converting disturbed eating to eating disorder becomes very, very high in these cases. Similarly, another research done in medical students in South India reports about 13% were with stress, body shape concerns, and these significantly contributed to the risk of eating disorders. So if we say as a whole, 2 to 2.4% of Indian population seems to be affected. Now, what are the eating disorders listed in the DSM criteria? Basically, there are 3 eating disorders which are listed in this: anorexia nervosa, bulimia nervosa. Binge eating disorders have now been included in DSM-5. It was not there in DSM-4. Avoidant and restrictive food intake disorders and other specified feeding or eating disorders, pica, rumination disorders. I've added to the list orthorexia, which is not there in DSM-5, and premenstrual dysphoric disorder, which many of us see but miss. So first question arises, why are adolescents at risk? We all know that puberty comes with self-esteem, self-identity, body image issues. So body image issues are something that may lead to eating disorders. Then comes social media. Every girl wants to have zero figure and every man wants to have developed muscles and goes to the gym. So social media's impression targeted at these adolescents' minds also makes them at risk. Next comes peer pressure. I will tell you, we have just had one boy, 18 years old, who collapsed at home, was brought by his father to the cardiology OPD, and this boy actually was found to have VT. So why VT suddenly? We couldn't find out why should this child have sudden VT. And then it was found that there was very low 1.8 potassium. And because, why was this 1.8 potassium? Because the boy was starving himself. He was initially obese and he was bullied at college, and therefore he was becoming anorexic. So this is how peer pressure works, bullying and then finally landing with VT in cardiology. Then, of course, perfectionism and anxiety. We will quote cases where people want a perfect body. 36, 34, and 36, 18, and 34, something like that, what we used to say. And then, of course, Sukanta sir has already said, family dynamics plays a big role. You will find many a generation Y parents, generation alpha betas, dieting, having intermittent diets and things of that kind, following those routines. So family dynamics on dieting also causes the adolescent to be at risk. Now this first case, 15-year-old who reported that over the past 6 months, she had lost 8 kgs. She has a BMI of 16, that is underweight. She avoids eating in front of. अपने थाली लेके अपने कमरे में चली जाती है. She cuts food into tiny pieces. और उसके फोन में कैलोरी काउंटर लगा है, तो प्लेट पे फोन लगा के she counts every little bit of calorie. She complains of feeling fat despite the fact that she's visibly thin. Then when medical signs come in, she has cold intolerance, she has bradycardia, she has dry skin and lanugo hairs on the arms and the back. Now, what did the heads show? That she was a perfectionist. She has withdrawn from social life and is very, very irritable. Such a case was now identified as anorexia nervosa. The characteristics of anorexia nervosa are that there is extreme food restriction, intense fear of gaining weight, and a distorted body image. पतली है, दुबली है, फिर भी वो जब अपने आप को देखती है तो वो मोटी समझती है. Then signs of significant weight loss and obsession with calories. कोई तो excessive exercise भी करने लग जाता है. Withdrawal from social activities. अरे मैं तो मोटी हूँ, दोस्त नहीं बनाती है, because छेड़ेंगे. And in females, in anorexia nervosa, you will find amenorrhea for more than 3 months. Then what are the risks? Risks would be, नहीं खाएगी तो malnutrition होगा, electrolyte imbalances होंगे, bradycardia होगा, osteoporosis and depression. She will land into all these risky things. Now, how was this case managed? This case was hospitalized. Bradycardia hai, rapid weight loss hai. ऐसे स्थिति में with a BMR of only 16, ऐसे स्थिति में she needed hospitalization, a heart rate of 48. There were unstable vitals. So why is she hospitalized? Number one, for monitoring and for refeeding. And a multidisciplinary team approach was taken along with the pediatrician, the nutritionist, and therapists were all roped in. There was a slow increase to prevent any refeeding syndrome, and family was also told to use a structured meal support. CBT was also done. CBT में they change her thoughts, you know, उसको दिखाते हैं कि ये जो thoughts है ये सही नहीं है, दूसरे thoughts को अपनाइए. So to help her challenge her distorted body images, CBTE was done, and after that a gradual return. After about 8 months of treatment, she improved in weight, she improved in her mental health, but she was still struggling further. So therapy was continued. Now there is this case where Jay is a 17-year-old male. He binges on large amounts of food at night and then goes and does vomiting. खाता है और उल्टी करता है, खाता है और उल्टी करता है. Now the weight is still normal, but his mother has said that she notices him that every meal के बाद वो bathroom जाता है. Now the physical signs are there. He has swollen cheeks. इनमें parotid hypertrophy होती है. He has swollen cheeks, he has dental enamel erosion, and he has Russell's sign in the knuckles. Knuckles में calluses पड़े हुए हैं. Feels ashamed, depressed, and he is struggling with self-esteem. So this is a case of bulimia nervosa. बुलिमिया नर्वोजा दो तरह के होते हैं, उसमें से ये पहला जो है ये बिंज पर्ज साइकिल है, खाता है उल्टी करता है. Some people may do excessive exercise to lose the calories. Some may use laxatives also. That boy that I had quoted who had VT was also using laxatives. So they may have a normal or fluctuating weight, swollen cheek, dental erosions, and Russell's sign. The main risk with these people is that they have electrolyte imbalances. जैसे मैंने बताया जो केस था उसमें 1.8 पोटेशियम हो गया था, and they have some mental health disorders. इसमें depression था. The second variety of this disorder is binge eating only. So this is without purging. ये उल्टी नहीं करेगा, laxative नहीं खाएगा, पर ये एपिसोड्स होंगे जब ये एक्सेसिव फूड कंज्यूम करेगा शॉर्ट टाइम में, एकदम गप्पा गप खाना जिसको बोलते हैं. ही विल ईट दैट, ही विल ईट इन सीक्रेट, किसी को दिखाएगा नहीं, छिपा के खाएगा. एंड ही हैज अ फीलिंग ऑफ गिल्ट और शेम अबाउट दिस. सो व्हाट आर द रिस्क? ऑब्वियसली छोटे टाइम में ज्यादा खा रहा है तो देयर बी ओबेसिटी, diabetes, and of course the whole myriad of hypertension, depression, lack of self-esteem, all these things. Now, how was Jay managed? Such patients can be treated with a psychologist who specialized in eating disorders. CBT again to address कि कौन सा वो emotional trigger है जिसकी वजह से this child is binging and why is he not being able to cope. So, coping strategies to be healthier with this child. In some cases, if it is very severe, we do use SSRIs, but remember, कोई भी SSRI यूज करने से पहले ifs and do's and don'ts आपको पेरेंट्स को बताना पड़ेगा, because in the first few months there is a suicidal tendency with these SSRIs. So you will have to be careful while prescribing and you have to take the parents into consideration. And nutritional counseling to establish structured meal patterns and avoid extreme restriction must be done. And the family involvement again to reduce the secrecy, to find out why, what are the emotional triggers, and for familial support and involvement in this child. Now, this child, a 14-year-old girl, has been avoiding solid food after choking on meat bone 6 months ago. Now, she eats only soft food. दही खाएगी, पोटैटो मैश करके देंगे तो खाएगी, बिल्कुल सॉफ्ट सा कुछ होगा तो वही खाएगी, ना कांटे वाला कुछ, ना बोन वाला कुछ. Anything that would choke her, she is afraid. So there is a food phobia here leading to weight loss and fatigue. No body image concerns, but she has an anxiety around choking. नहीं गले में लगता है, ऐसे बोलती है. And what are the medical concerns? That she has anemia, she has fatigability, and she has stunted growth. This is called avoidant or restrictive food intake disorders. So avoidance of food due to sensory sensitivity, हो सकता है choking हो सकता है उससे vomiting ज़्यादा हुई हो, or lack of interest in eating. And signs, what are the signs? There is a limited variety in diet. She's not taking all of the diet. She's taking only soft food. And as a result, there is nutritional deficiency. There may be low weight and anxiety around eating. कभी भी खाने के बारे में बात करेंगे तो बोलेगी नहीं ये नहीं खाएंगे वो नहीं खाएंगे. हम बोलेंगे सोचेंगे picky eater है, but this is actually avoidant restrictive food intake disorders. So there will be growth delays, there will be malnutrition, and there will be social isolation in such cases. तो मैनेजमेंट क्या होगा इसमें? मैनेजमेंट होगा कि आप ग्रेजुअल एक्सपोजर, पुराने जमाने में वो विष कन्या बनाते थे थोड़ा थोड़ा करके टॉक्सिक सब्सटेंस देके, वैसे ही इसमें एक ग्रेजुअल एक्सपोजर विद साइकोलॉजिस्ट टू रिड्यूस द फूड रिलेटेड एंजाइटी. The speech therapist is roped in, who will advise on chewing, swallowing confidence. Dietitian for a nutritional plan to reintroduce other textures. सिर्फ soft नहीं, semi solid, फिर solid, धीरे धीरे introduce करेगी. And parental support of course for a low pressure. खाओ 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 नहीं करने का है, low pressure eating environment. One of the commonest things that we see is that पाइका. अब पाइका में हम लोग देखते हैं कि दे आर ईटिंग नॉन फूड सब्सटेंसेस. सो पाइका का डेफिनेशन ही ये है दैट इट इज ए परसिस्टेंट कंजम्पशन ऑफ नॉन न्यूट्रिटिव नॉन फूड सब्सटेंस फॉर एटलीस्ट 1 month and should be inappropriate to the developmental level of the adolescent, because this is found mostly in those children who have a developmental issue. So इसमें risks तो obviously there are iron zinc deficiencies, there are GI blockages, there could be a poisoning because of non-food substances. और कई बच्चों को आपने देखा होगा चौक चाट रहे हैं, दीवार चाट रहे हैं, ऐसे वाले बच्चे मिलते हैं. So what do we do? Assessment. Number one, because a lot of paint, varnish, and the whitewash, they have a lot of lead. So sometimes we land up with lead poisoning. So we need to be very watching for lead poisoning. And another thing is we need to rule out any GI obstruction, because कभी कभी ये लोग बाल खा लेते हैं या पिन्स खा लेते हैं या नेल्स खा लेते हैं. बेजोयर के लिए भी देखना पड़ता है कि कोई GI obstruction because of that ball of non-food substance हुआ है कि नहीं है. Then check for nutritional deficiency, mainly iron, calcium, zinc. Then assess for any comorbid. As I said, developmental issues में होते हैं. तो इन बच्चों में you can have ASD, you can have OCD, you can have intellectual disabilities. So उनका भी comorbid situations का you need to assess. And medical management will consist of correcting the deficiencies and deworming the child and looking for bezoars or other things which could be obstructing the intestine. Now, pharmacological therapy would involve comorbid situations like OCD. Sir was saying that OCD can be managed well. And then you have a multidisciplinary approach. A word on behavioral therapy. Behavioral therapy is done by applied behavioral analysis. It's called ABA, where we reinforce the child for his good behavior through rewards, and sometimes we do a little aversive conditioning. Like आपने उसके मुंह पे अगर उसने चौक खाया तो उसके मुंह पे bitter कुछ रख दिया. So these are, be careful, but aversive conditionings are also done. Next is habit reversal therapy करते हैं, teaching awareness and replacement behavior. अच्छा तू चौक चाट रहा है, चल तुझे ये टॉफी देती हूँ, ये चाट ले. So like that. And environmental, so that we remove access to such things and have a close supervision on the child. So now we come to rumination disorders. अब rumination क्या होता है? जुगाली करना. जुगाली जैसे बार बार करते हैं ना, गाय बकरी लोग करते हैं, वही चीज. Rumination disorders. These are characterized by regurgitating food. There is no medical condition, remember. GERD नहीं हो रहा है, pyloric stenosis नहीं है, but re-chew कर रहा है, re-swallow कर रहा है, या sometimes spit out कर रहा है. And at least for a month, these things should be there. These are usually associated with stress, with neglect, with intellectual disability or anxiety. and the risks of malnutrition, weight loss, societal embarrassment and avoidance are always there. So if this is there, how do we manage? So there is other issues or not, GRD वगैरह है या gastroparesis है कि नहीं, we need to check that out first. And once we've done that, we check for malnutrition, electrolyte imbalance or weight loss. And then we go for again behavioral therapy, ABA, and positive reinforcement or habit reversal trainings. Parental training is important. The parents must understand the triggers, and if the triggers are there, they will positively reinforce the child and increase the mealtime interactions so that the child sits at the table and gets distracted and eats with them. Now, CBT again for the thought pattern, the coping strategies, and nutritional support, which addresses the growth delays. Now, orthorexia is very it's a common thing, but sometimes we miss it and it is not officially there in DSM. So this is obsessive. मैं इतना healthy खाऊंगा to the extreme degree मैं healthy खाने के अलावा कुछ नहीं खा सकता. So this is when they avoid entire food groups and their anxiety is totally ki unhealthy खा लिया. So sometimes, you know, when they are in society, they will not eat. They will have, because of that, अगला बोलेगा कि इनको बुलाए ही क्यों, तो कुछ खाते पीते हैं नहीं, ये हमारे वाले खाने को बुरा बोलते हैं. So there will be a social isolation due to dietary restrictions. So there is psychological distress in such cases. There is malnutrition and they're very rigid in their eating habits. ये healthy ही खा के मानेंगे. अब DSM में आता है other specified feeding or eating. DSM is very strict about certain things. उसके criterion supportive होने चाहिए. But remember, some of these will not fully fit into the criteria. So DSM ने उनके लिए थोड़ा सा looseness छोड़ा है कि अगर they do not full fit into the total criteria, but it seems to be there, then we will put them into other specific OSFED or other specified feeding and eating disorders. So anorexia nervosa हो रहा है, पर significant weight loss भी नहीं हो रहा है, underweight भी नहीं हो रहा है. Purging disorder है, लेकिन binging नहीं है. Night eating है, लेकिन weight loss में हम उसको binging नहीं कह सकते. तो ऐसी स्थिति में this is OSFED or other specified feeding or eating disorders. Now, this is a very important thing we should know for all the adolescent girls, that there is a condition called premenstrual dysphoric disorder or PMDD. इसमें DSM-5 in 2013 has actually classified it as a psychiatric disorder. And ICD-11 में भी ये आ गया है as a disorder of the reproductive system. इसमें mood swings होती हैं बच्चियों को, anxious, irritable, कभी-कभी इतना तेज गुस्सा करने लगते हैं, and then they are sad, they are suicidal, and there is binge eating to add to it. So this premenstrual dysphoric disorder also has binge eating, but actually where is the origin? The origin is somewhere in the hormones. So there again we need to know this particular thing while we are examining an adolescent female with binge eating. So early recognition and engagement, that is our approach. The first thing is to look for weight loss, food rituals, excessive exercise, social withdrawal, mood changes, or distorted body image. So approach them with empathy. अरे खाते नहीं हो, करते नहीं हो. Instead of that, avoid blaming and confrontation, and open communication करना है. Open communication करना है. I feel that I have noticed some changes and I'm concerned. Can we talk? Or how do you feel when you look at the mirror? Can you describe your thoughts? Why don't you like? What don't you like about your appearances? So these are a few questions. How much of interference does it do to your life? Which you can always ask the adolescent. The second point I would say was comprehensive medical and psychological assessment. So you have to look out and sort of rule out the other disorders which may be associated, and we may need to find the associated comorbid situations. So both ways, रूल आउट भी करना है कुछ कंडीशंस को और इंक्लूड भी करना है, देखना भी है कोमॉर्बिड सिचुएशंस के लिए। एंड ऑलवेज असेस द बिहेवियर की हो क्या रहा है। न्यूट्रिशनल रिहेबिलिटेशन मतलब सेफ फूड समझाना है, फियर फूड नहीं समझाना है। लाइक हम कहते हैं कि वी फियर गॉड, वो नहीं होना चाहिए, वी शुड लव गॉड। सो फूड इज समथिंग विच शुड बी टेकन विथ अ लॉट ऑफ sort of goodness in the mind also. इसलिए कभी कभी हम लोग लाइट म्यूजिक चलाते हैं। सो सेफ फूड नॉट फियर फूड। एंड एनकरेज रेगुलर मील्स, जो हमारे पूर्वज बना गए हैं 3 टाइम खाना बीच में स्नैक्स, वो वाला ठीक है। ये रिस्ट्रिक्टिव और बिंज ईटिंग साइकिल, खूब डाइट किया फिर खूब खा लिया, दैट्स नॉट द राइट थिंग। यू शुड एनकरेज अ रेगुलर मील। एंड रीफीडिंग सिंड्रोम ना हो, इसलिए जब सिवियर केसेस को हम लोग रीफीड करते हैं, so you need to see to it that you are monitoring the person for refeeding syndrome. Psychological therapy, sir Sukanta sir has also been talking about CBT. So you have CBTE in eating disorders, you have FBT or family based therapy, and you have to address the emotional distress, issues of self-esteem, issues of self-harm, and for that you need to all train in the Adolescent Health Academy. Involving the family, so the family को ये समझाना है कि ये डिफाइंस बिहेवियर नहीं हो रहा है कि ये नहीं खाना, वो नहीं खाना, वो नहीं करना, ये नहीं. दिस इज अ नॉर्मल प्रोसीजर इन सच अ चाइल्ड हु हैज एन ईटिंग डिसऑर्डर. सो वी नीड टू हेल्प हिम एंड गिव हिम सपोर्ट इंस्टेड ऑफ शेमिंग हिम और पुटिंग प्रेशर ऑन टू हिम. सो फैमिली मील्स सपोर्ट करने हैं, पॉजिटिव रीइंफोर्समेंट करना है, and long term, all these, like I said, that girl needed an 8-month therapy, she's still struggling. So it is a long term management. आज कह दिया और कल हो गया, ऐसा नहीं होता है. They need a lot of support, maybe years of support to prevent relapses also. And you must avoid diet culture. That is very important. जो parents को देखेंगे करते ना, आज dieting कर रहे हैं, कल dieting कर रहे हैं, वही वो अपनाएंगे. So remember, avoid the diet culture. And to sum up, keep in mind that these things are commonly missed. High risk identification of chronically ill, too thin or too obese patients should be done. There should be poor, low mood, substance abusers. You need to do a heads in all of them. Give anticipatory guidance about food to the adolescents who are coming into your clinic and also to the parents. Evaluate, there are questionnaires there which you can use. School health programs also create awareness on eating disorders, and treatment should be timely with referral. So treatment would involve CBTs and sometimes pharmacological therapy. Consider hospitalization when the BMI is less than 70%, 75%, when there is brady, hypotension, hypothermia, or acute electrolyte imbalances and dehydration, or active suicidality or psychiatric crisis. This is when you must hospitalize and you must refer, because it is a multidisciplinary team which should be taking care of such a child. So they present differently. Some may involve weight loss, some may not involve weight loss, some may involve binging, purging, some may involve only binging or avoidance. So this is a huge spectrum of eating disorders, and early intervention must be done to prevent severe complications. Family involvement is a mainstay and multidisciplinary is a mainstay. Here are a few references for all of you. And then again, healthy eating, promote it, grow, glow, and go. Thank you so much for patient hearing.
Thank you so much, Piyali ma'am. Pritish sir, you are there? Dr. Pritish sir? Yes, Dr. Pritish sir, you are there? Piyali ma'am, it was a wonderful presentation as always. It was very engaging. And you had
Thank you, ma'am.
simplified. Yes, Pritish
Thank you,
sir is
ma'am.
here.
Thank you, ma'am. A very excellent presentation. And now I hand over to Dr. Mala Chaudhary.
Thank you, sir, for chairing the session. And as always, yes, it was an excellent session, Piyali ma'am. We really appreciate the wealth of the knowledge you shared on all the eating disorders. Now we'll take the question answer session. Yes, ma'am. We'll take the question answer session. I think Dr. Sukanta sir has been answering
Yes, I
in
have
the chat box itself.
questions in the chat box. What I
Yes,
have
sir.
seen.
You absolutely. You have quite very well answered in very detailed one within the chat box itself, sir. Do I see new questions now? It's all appreciation, all appreciative messages. So I acknowledge the presence of Himabindu ma'am again till the last of the session. Dr. Anup sir is here. Dr. Nilay Mazarkar sir is there. Dr. Sudhakar sir is here. Dr. Kavita madam is here. Lot of participants. Dr. Rashmi Dwivedi ma'am already over here. Right.
May I request Dr. Bafna to comment on
Yes.
our presentation, sir? Your experience.
Absolutely. Bafna sir, looking for your blessings, sir.
Ji. Thank you very much, Dada. First of all, I must congratulate AHA Chhattisgarh and Sangeeta for keeping the flag of Chhattisgarh very high.
Thank you, sir.
We scored highest marks last year, and this is also under the leadership of Himabindu. Definitely will go ahead. So far as Sukanta Dada is concerned, when we listen to him, his experience speaks. और रही बात प्याली की, वो तो उसका नाम प्याली के बदले प्यारी रहना चाहिए.
Yes, sir.
उसके प्याले में उसका इतना खजाना है कि आप पूछिए मत. रही बात खाने पीने की, टू माय पेशेंट्स ऐसे नाश्ता जहांगीर की तरह, दोपहर का भोजन अमीर की तरह और रात का भोजन फकीर की तरह.
Yes.
दूसरी बात, खाओ पियो छको मत, देखो भालो तको मत, बोलो चालो बको मत और चलते रहो थको मत.
बहुत बढ़िया.
तो ऐसा है, प्याली को सुन के तो खाली प्याले सब भर जाते हैं. एंड शी रियल गुड. और सुकांता सर ने तो बहुत सारगर्भित बातें हम सबको बताई है. एंड नेचुरली दिस वाज अ वेरी गुड सेशन. I must congratulate Sangeeta for this session. Thank you so much.
Thank you, sir.
Ananda.
Thank you.
Enjoy.
Thank you, sir. Thank you, sir.
Thank you so much, Bafna sir. Thank you so much. Our madam is Ashok Mehta sir. Would you want to speak something, Ashok sir?
Yeah, this was a very good session. Actually, सुकांता सर उधर हैं तो सुकांता सर का पूरा एडवांटेज अपने को लेना चाहिए. And eating disorder was something which was never talked about. So I congratulate team AHA Chhattisgarh to have picked up very good topics, which we are usually not listening to any conferences or not being discussed. And it actually, now the things have gone into mind, we will start looking at the things more intently. So it was a good session, and both speakers, as expected, were excellent. And it was a very nice session. Thank you.
Ashok.
Thank you.
Ashok.
Sir.
3 अक्टूबर को पियाली को फिर से सुनोगे राजनांदगांव में.
हाँ, वो तो आ ही रहे सर. बहुत बढ़िया, बहुत बढ़िया
सर, बहुत बढ़िया.
बहुत अच्छा.
उस दिन मैं एक दिन का रहूंगा सर.
दे रहा हूँ ना, वो मुकर नहीं सकती है.
I'll be 1 day old on that day. 2nd is my birthday.
Wow, 5th is my birthday.
Second को है sir.
So we are both Librans. Okay.
Yes.
Right.
So
Madhushri Deshpande madam is also here. Madam would like to speak anything? Madhushri ma'am?
I think she had just left.
Okay, madam. Right.
So I congratulate Sukanta sir and Piyali madam on behalf of CGAHA. Sukanta sir.
Yes.
Yes, sir. Good evening. You are wonderful.
Thank you so much.
And Piyali madam, you have done a great job.
Thank you.
Congratulations, Sukanta sir, our past chairperson, immediate past chairperson.
Thank
And
you,
of
thank
course,
you.
Piyali,
We are planning
Finally, yes,
midterm same
yes.
at Kolkata. You have to come,
Sure,
Mavindu.
sir, sure.
Yes,
And
so honorable all, thank you, sir, for inviting in the Central Pedicon. Honorable all dignitaries, all central and state academic mentors, distinguished esteemed guest speakers, the chairpersons, Chhattisgarh Academy of Adolescent Health finally extends a heartfelt gratitude for making this webinar a huge success. Thank you for all the active participation, for engaging questions, and for all the thoughtful insights which could make this event memorable. Thank you, Sukanta sir. Thank you, Piyali ma'am. Thank you, Honorable Hima Bindu madam. Thank you so much. So Team Chhattisgarh AHA again has made its best efforts to create a valuable learning experience for all of us. And my sincere appreciation to everyone involved in making this webinar a huge success. We're grateful for this opportunity to collaborate together. Thank you so much, ma'am. Thank you all.
congratulations,
Thank
Chhattisgarh.
you, thank you.
Mala
Thank
probably forgot today is Mahavir Jayanti. तो आज के दिन अगर सुकंतो को सुना और पियाली को सुना तो आज तो महावीर जयंती सफल हो गई.
Absolutely. Absolutely, Bhakna sir.
Yes,
Great.
sir.
It was a great get together. Thank you all members. Thank you so much.
Thank
With
you.
all of
Thank you, thank you.
Thank
Good
you
night.
so
Good
much.
night,
Thank
sir.
you.
Good
Night,
night.
good night,
Good night,
Good
night,
night and
night.
namaskar.
Thank
Thank
you.
you.
Good night.